Okay, so I'm going to be talking about brain cancer today. Specifically, I'm going to talk about my 54-year-old patient named Diana, and she was recently diagnosed with a grade 4 glioblastoma, which is a very serious, a lot of times deadly form of brain cancer. Survival rates are usually not very good. For the elderly, it's usually around 4% with a 5 year span, and then 5 year survival rate for people who aren't the elderly, younger people, is still about 17%. So the rates aren't very good for survival, so it's pretty serious. And the treatment options will vary for every patient, what their predisposed medical conditions are, and then how they want to choose to follow treatment. We'll go over some of the treatment options and then nursing considerations. So with a lot of types of brain cancers, and specifically glioblastomas, a lot of the side effects that we're going to be expecting to see or monitoring for, the biggest one is going to be headache. It'll be very severe. A lot of the times with these patients, when they change positions or when they lean over with their head forward, it will get really bad. And then, of course, with any cancer, fatigue is going to be one, drowsiness. Personality changes are going to be something we're going to really need to monitor closely. Confusion, function changes, so, loss of balance, coordination. Blurred vision, since the tumor is going to be located in the brain, that's really close to where your eyes are, obviously. So vision changes is something we're going to monitor for. Irritability, behavioral changes, and then depression as well, are a lot of things that we're going to monitor for. And then, of course, a huge thing is pain, of course. So we're going to be doing pain assessments a lot. For monitoring the tumor, during treatment, a lot of the times they will monitor with MRI to decide how it's changed, if it's moved, metastasized, and then that's how they kind of tell for staging as well. But to officially diagnose a brain tumor, they usually use a cerebral biopsy to officially diagnose it, though. And then for treatment options, if the patient and the medical care team decide that they want to be aggressive with it, they will, maybe do forms of chemo or radiation, and then surgery is a big one that they can try to do. A popular surgery would be a craniotomy, which is where they drill a hole in the skull, localize the tumor, and then try to remove as much as they can. So that's one, which is a very serious procedure, obviously, because you're opening the brain, you're opening the skull and exposing the brain. So there's going to be a lot of prep for that, a lot of monitoring afterwards. So that is one of them. So for, just in general for monitoring these patients, obviously the ABCs are going to be huge. Maintaining the airway, since the brain, the tumor is up here, your airway is right here, and so it's so close to where you can have an obstruction, and so that's going to be huge. And then monitoring neuros are going to be like one of the top assessments that we're going to do, obviously. And so a lot of the times with these patients, we are going to do like a full neuro assessment every 2 hours, and then sometimes every 1 hour as well, we'll see it. And then a huge thing with these patients are they're at huge risk for seizures. So with that being said, with a lot of these patients, we will implement seizure precautions. And then so that would include, having seizure pads on the bed, on the railings, making sure that we have IV access, like ready and available. So if they start, seizing and we're having an uncontrollable seizure that's not stopping, we may be able to get an order to push something IV like lorazepam, to get the seizure to stop. And then we want to make sure we also have oxygen set up. That's another airway thing. We want them to be able to breathe. And so we want, some type of oxygen supply set up nearby. And then also, a lot of the times for the precautions, we'll have suction set up nearby as well. So that would be like a yonker that we can suction out their mouth if they start having secretions, and we don't want that to interrupt their airway either. So yeah, and then another thing with a lot of these patients, for medications, for monitoring, they will do a lot of anti-seizure medications, of course. Two common ones are Keppra and Dilantin. And so when they're on these medications, of course, we're going to be monitoring seizure activity. Is it, getting worse? Is it getting better? Because you may need to adjust the dose. Maybe they're not getting enough. And then it's going to be really important for the nurse to be administering these medications on time every day, at the same time, to be able to control seizure activity. And then with a lot of these medications, a big side effect is nausea. So with that, we may also have an order for an antiemetic like Zofran that we can give to them if they're experiencing nausea, and treat those symptoms as well. Another medication that's common are going to be corticosteroids, because they decrease inflammation in brain tissue. So with that being said, having a tumor that's already pushing on the brain tissue, we're going to try to give them a corticosteroid to help decrease the inflammation in the brain. So like I said, a lot of complications. There's the seizures, so we're going to monitor for that. And then another complication of having a brain tumor is herniation. So basically that's when the tumor will put pressure on brain tissue and cause swelling or bleeding, which is not good. So we're going to monitor for that as well. And then also we're going to need to monitor input and output, because with tumors, sometimes they can grow and put pressure on the pituitary gland, and the pituitary gland secretes ADH, so that kind of controls, the us, urinating and whatnot. So monitoring I's and O's, and then a lot of the times, if it's putting pressure on the pituitary gland, it can cause like excess urination, so the patient can just be peeing all the time. So we'll, if they're, peeing all the time, they're losing those fluids, so we'll need to provide fluid replacement as well. And so for nursing diagnosis, I came up with a couple. Acute pain related to the tumor present, evidenced by verbal complaints of headache. So we're going to want to make sure we're treating the pain. It's really important, not only for all cancer patients, but especially these ones, because with the survival rate being so low, if all else fails and, the person isn't going to live very long, and we know that, we want them to be as comfortable as possible for the time that they do have. So that's going to be a huge nursing diagnosis. Another thing too that I have is risk for injury due to the tumor present, evidenced by seizure activity. So, that's where the seizure precautions are going to come into play, and we're going to make sure the patient is safe, and we can decrease that risk as much as we can. If they're going to have seizures, we just want to make sure that they're safe. So, going in with your patient, and this is Diana, and we have went through all treatment options with her, and unfortunately they've failed, and the tumor continues to grow. So with her physicians and her families decided that it's just time to make her comfortable. They've pursued hospice, and so we're just, we're still monitoring, the tumor present, doing all the neuros and everything like that, because we do want to note changes. But we are trying to make her as comfortable as possible. So when going in with her, we're going to do, still do the neuro assessments, and to go over, kind of like the neuro assessment, we'll be doing, an eye test. So, we'll be taking a pen light, looking at, if her pupils are reactive, round, and then checking her vision. Is she, still able to see? With a lot of these tumors, they will interrupt vision, and, that can be kind of scary for patients too if they can't see. Hearing test, so we're going to make sure that they can, hear us. We'll test reflexes, balance and coordination, touch, smell, how, reactive they are with their muscles, and then mental status, abstract thinking, and speech. So a lot of the times with tumors, they can mess up with the patient's speech, how they're talking. We monitor that. Memory, obviously, we go through the, can you state your name, date of birth, where are you? What's the situation? And we monitor that as well. So we go in, we do a full neuro test, and then, another big assessment besides the neuro is going to be the pain. So we want to make sure that we evaluate the pain. We want to put interventions into place for the pain. And then after we put the interventions into place, we're going to monitor the effectiveness of the interventions, and then we can respond accordingly. So with Miss Diana here, right now she is on hospice. We are, she's on comfort cares. We're just making her as comfortable as possible. So when I come in, I'm, really going to assess her pain and comfort level. And right now she is on scheduled morphine every 4 hours. So I'm going to make sure that's effective. If it's not, we have a PRN dose that we can give in between. So I can give that. And, if she's experiencing nausea, as a side effect, then we can do, some PRN, Zofran, and then we also can try non-pharmacological interventions, such as I'm going to make sure that she's repositioned, that she's laying comfortably. We have warm packs, hot packs we can do. We have massage techniques we can do. And just creating a very calm, low stimulation environment is helpful as well. So that's it.